Hello everyone. Welcome back to this series of lectures in endocrinology. So in the last few sessions, we have been discussing about the pituitary gland. Now we will be continuing on in our series and we will be discussing about the thyroid gland. So in today's chapter, we will be discussing about the thyroid gland physiology and testing. So let's begin. So first, we will understand the basics of the thyroid gland. The thyroid gland is basically a butterfly-shaped organ. The thyroid gland is basically a butterfly-shaped organ which is present in the front of the trachea. It is present in the front of the trachea between what? Between the cricoid cartilage and the suprasternal notch. Between the cricoid cartilage and the suprasternal notch. Okay. So the thyroid gland is a butterfly-shaped gland which is present between the cricoid cartilage and the suprasternal notch in front of the trachea, and it has a weight of about 12 to 20 grams. It has a weight of about 12 to 20 grams. So it develops from the floor of the primitive pharynx. It develops from the floor of the primitive pharynx. And it has specialized cells called the medullary C cells which are involved in the production of calcitonin. Okay. It has specialized cells called medullary C cells which are involved in the production of calcitonin. Behind the thyroid gland, you have the 4 parathyroid glands. So behind the thyroid gland, you have the 4 parathyroid glands. The transcription factors involved in the development of the thyroid gland are TTF1, 2, NKX2 and PAX8. So you just have to know the names TTF1, 2, NKX2 and PAX8. So let us understand the regulation of thyroid hormone synthesis. So what are the important points about the regulation of the thyroid hormone synthesis? So we know that the first hormone is your thyrotropin-releasing hormone which is produced in the hypothalamus. So there is thyrotropin-releasing hormone which is produced from the hypothalamus which stimulates the anterior pituitary to produce your thyroid-stimulating hormone. It stimulates the anterior pituitary to produce thyroid-stimulating hormone, and the TSH acts on the thyroid gland to produce your T4 and T3 which are your thyrotropins. Okay. And these thyrotropins have an feedback inhibitory effect on the TSH and feedback inhibitory on the hypothalamus as well. So they have feedback inhibitory effects on the hypothalamus and the pituitary. So TRH causes stimulation of TSH, TSH causes the thyroid gland to release your thyrotropins. Okay. And when you look at the histological examination of the thyroid gland, each thyroid gland is characterized by the presence of follicles. It is characterized by the presence of follicles. These follicles are basically comprising of these kind of columnar cells. Okay. And the protein which is present within these follicles is called your thyroglobulin, TG, or your thyroglobulin. Okay. So clearly here we have just looked at some of the salient features about the anatomy and development and the histology of the thyroid gland. Now let us look at thyroid hormone synthesis. Okay, so let us look at thyroid hormone synthesis. So the steps which are involved in thyroid hormone synthesis is very important because any damage or any alteration in any of the steps can cause hypothyroidism. Okay, so the first step which is involved in your thyroid hormone synthesis is your iodine uptake. So the thyroid gland has a preferential uptake of iodine. So how much ever iodine is present in the plasma, nearly 50 to 60% is taken up by the thyroid gland itself. Right. So within the follicle, we are looking here at the follicular cell. Each follicular cell has a basolateral membrane and an apical membrane. The apical membrane is towards the center of the follicle. This is your apical membrane. This is your basolateral membrane. Okay. So the first step in your thyroid hormone synthesis is this iodine uptake, and this is brought about by a sodium iodide symporter. NIS stands for sodium iodide symporter, which is present in the basolateral membrane of your thyroid follicular cell. So this sodium iodide symporter helps in the transport of iodine within the follicular cell. Apart from the thyroid, the sodium iodide symporter is also seen in the placenta. It is also seen in the salivary glands and in the kidney. Okay. So apart from the thyroid gland, the sodium iodide symporter is also seen in the placenta, in the salivary glands and in the kidney. Okay. So the first step is your iodide uptake. First step is your iodide uptake. And why is the sodium iodide importer important? Because any damage to the sodium iodide importer can result in congenital hypothyroidism. Okay, fine. Now, once the iodide is taken up into the follicular cell, it undergoes a process which is called as organification. Okay, so what is this process of organification? Now, we know that there are thyroglobulin molecules or moieties which are present within your thyroid follicle, right? So, the iodine which is present here is then added to the thyroglobulin molecules. To what? To the tyrosine residues. To the tyrosine residues within the thyroglobulin molecule. So, this iodination of tyrosine residues. The iodination. So, there is iodination of tyrosine residues within the thyroglobulin molecules, and this is what we call as organification. This is what we call as organification. Okay. So, how is this brought about? How is this brought about? So, once the iodine enters into the follicular cell, this is acted upon by Duox enzyme and Duox proteins. Okay. So, you have Duox enzyme which acts on this iodine. Apart from that, you also have some enzymes like thyroid peroxidase, and these basically helps in the oxidation of your iodine residues to iodide. And meanwhile, hydrogen peroxide also acts on the iodine residues and oxidation of iodine happens. Once this oxidation happens, this iodide molecule is incorporated into the tyrosine residues within the thyroglobulin. So, your thyroglobulin combines with your iodide, and this process is your iodination, and this entire process is called as organification. So, the iodination of the tyrosine residues is called as organification. Okay, clear. Then, the third step, once the organification is done, so your tyrosine residue plus one iodide molecule results in what? It results in a molecule called monoiodotyrosine. It results in a molecule called monoiodotyrosine. Okay. So, once one molecule of monoiodotyrosine is formed, it combines with one more molecule of monoiodotyrosine to form diiodotyrosine, and this is what we call as coupling. So, the third step is your coupling reactions. Can you see here? Monoiodotyrosine, diiodotyrosine, then they combine with one more molecule of MIT to form your triiodotyrosine or T3 and T4. Okay. So, this process of coupling happens. So, your final product is what is your T3 and T4, which is nothing but your thyroid hormones. Okay. Now, this T3 and T4 are then from the apical surface carried back to the basolateral membrane. They are carried back to the basolateral membrane. So, initially they can be stored within the thyroid follicular cells itself, and then whenever it is required, it is released. It goes from the apical surface to the basolateral membrane, and they are released as T3 and T4. The thyroglobulin molecule is removed out by the enzyme dehalogenase. The dehalogenase enzyme basically restores your thyroglobulin. It restores it back so that the next molecule of iodine can act on it. Okay. So, this is about how your thyroid hormone is synthesized. So, T3 and T4 are your active thyroid hormones. So, the first step is your iodide uptake, second step is your iodination, and there is oxidation of iodide. Oxidation of iodine and iodide residues are added to tyrosine. This is brought about by Duox enzymes, and this is called as organification. Then once your monoiodotyrosine is formed, it combines or undergoes coupling reactions to form diiodotyrosine, then T3 and T4. The T3 and T4 are then released via your basolateral membrane. Okay. So, these are the various steps involved in your thyroid hormone synthesis. Now, another very important syndrome is your Pendred syndrome. So, there is a transporter which is present in your apical surface called pendrin. Whenever there is a damage to this transporter, you can have congenital hypothyroidism with sensory neural hearing loss, and this is called as Pendred syndrome. Okay. So, this is about your iodide transport and synthesis of thyroid hormone. Now, what is this Wolff-Chaikoff effect? An important effect that you have to know is the Wolff-Chaikoff effect. So here, excessive iodine intake can transiently inhibit your thyroid iodide organification. So we know that iodine is required for organification, but external excessive iodine intake can inhibit your thyroid iodide organification, and this is what we call as Wolff-Chaikoff effect. Okay, clear till here? So this is about your thyroid hormone synthesis. So now let us look at the differences between T3 and T4. Let us look at the differences between T3 and T4. We know that T3 and T4 are the final active forms of thyroid hormone. Okay, so they are triiodothyronine and tetraiodothyronine. Okay, so T3 and T4, once they are released, they are usually bound to proteins. So what are the proteins to which they are bound? They are bound to thyroid binding globulin, transthyretin and albumin. This we should be aware of, because any changes in these protein levels can actually alter the T3, T4 levels which you are measuring. Okay, so once the T3 and T4 are released, they are bound to certain proteins which are your TBG or thyroid binding globulin, transthyretin and albumin. Now we'll look at the differences between your T3 and your T4. Okay, so let us look in terms of serum concentrations. The serum concentration, total hormone of T4, you don't have to know the values, you just have to understand in essential what we are trying to say. So total hormone of T4 is much greater than T3. So the concentration of T4 is much more than that of T3. Then fraction of total hormone in the unbound form. So when you look at the fraction of total hormone in the unbound form, this is higher for T3. This is higher for T3. So T4 is only 0.02% of it is unbound, but T4 is only 0.02% of which it is unbound. But when it comes to T3, it is usually much more unbound. Okay. But if you see the total unbound hormone concentration, this is the important difference that I want you all to focus on, and you will also get confused about. Okay. So this is the other important point that I want you all to focus on, which you can also get confused about. We know that T3 is much more unbound, right? So that's what we saw here. The fraction of unbound T3 is more than T4, right? This is what we saw here. Okay. But why is that the total concentration of unbound hormone of T4 more than T3? Yeah, why is that so? This is because on the whole the total hormone concentration of T4 is much higher. T4 total concentration is much greater than T3 total concentration. Okay, that is the reason why, though it exists in a lesser fraction of unbound form, when you measure the concentrations, the concentration of unbound T4 is also higher than T3. Also, T3 gets degraded faster. T3 gets degraded faster. So before even you can measure your concentrations, it can get degraded. But T3 exists in the unbound form more than T4, right? So this is why this difference here. Okay, this is very important. So the total concentration of T4 in the serum is much higher than that of T3. T3 exists in a greater fraction in an unbound form than in a bound form. But still, even if you measure the unbound fraction of T3 and T4, unbound fraction of T4 is greater than T3, though it is less unbound, that is, though it is more bound to proteins, because the total concentration itself is higher, the amount of unbound concentration also will be higher. Also, T3 is degraded faster. Okay. Then look at the serum half-life. The half-life of T4 is greater than T3. Then we look at the relative metabolic potency. The T3 is much more potent than T4. These are the most important differences which you have to remember between T4 and T3. Okay, fine. Now, T4 is converted into T3 by means of this group of enzymes which we call as deiodinases. So, T4 is converted to T3 by this group of enzymes that we call as deiodinases. So, type 1 deiodinase is found in the thyroid, liver, kidney. This has lesser affinity to T4. Type 2 deiodinase has higher affinity and it is found in pituitary, brain and brown fat. Okay. Now, what we have to know is that there is a type 3 deiodinase and what is its clinical significance. So, this type 3 deiodinase is basically responsible for conversion of T4 or T3 into reverse T3. Reverse T3 or RT3 is an inactive form. It is an inactive form. Okay. So, what is the clinical significance or clinical point you have to remember is that reverse T3 this type 3 deiodinase activity can be increased in certain forms of hemangiomas, and this is associated with what? Inactivation of your T3, T4. So, you can have a type of consumptive hypothyroidism. Okay. So, this is about your deiodinases and a clinical point about your type 3 deiodinase. Okay. Fine. Now, let us look at another important clinically relevant condition, which is your euthyroid hyperthyroxinemia. Okay. So, what is this condition called as euthyroid hyperthyroxinemia? So, in these conditions, what we call as euthyroid hyperthyroxinemia, I told you that these T3 and T4, when they are released from the thyroid gland, they are bound to proteins. Which proteins? Thyroid binding globulin, albumin and transthyretin, right? So, any problem with the proteins can alter your T3, T4 measurement in the serum. Okay. So, whenever there is a problem with the protein, T3, T4 levels will also be altered. Okay. But which T3, T4? It is your total T3, T4. So, whenever you measure your total T3, total T4, if there is a problem with any of these binding proteins, then your total T3, T4 levels will be altered. Okay. So, this results in an alteration in your total T3, T4 levels, but the free or unbound T3, T4 will be normal, right? And what about the TSH? The TSH will also be normal. Free levels will be normal. So, what are the conditions where these proteins are affected? This is what we are going to look at. This is called as euthyroid hyperthyroxinemia because the thyroid gland doesn't have a problem. The thyroid gland functions are normal. It's only your total T3, total T4 levels which are varying because of changes in the proteins. So, first we have the familial dysalbuminemic hyperthyroxinemia. So, here there are autosomal dominant mutations in the albumin protein. So, what happens here? The total T4, like I had mentioned, is increased. So, you will think that there is some form of hyperthyroidism which is not true. So, there is normal unbound T4. The total T4 will be increased, but the unbound T4 is normal. Okay. Then, TBG excess, the other protein, which is your thyroid binding globulin. So, TBG excess can be familial, which is obtained as an X-linked, which is inherited as an X-linked form. Then it can be acquired. What are the acquired causes of thyroid binding globulin excess? Pregnancy, cirrhosis and hepatitis, or even drugs like OCPs. Okay, so all of these can cause an increase in the TBG binding, and hence what happens? There is an increase in the total T3, T4, but again the free T3 or the unbound T3, T4 are normal. Then third, there can be mutations in your transthyretin protein. Right, so this can be seen in an acquired form like islet cell tumors or inherited as an autosomal dominant fashion, and even here there is increased total T3, T4 normal unbound levels. So, this is your euthyroid hyperthyroxinemia. Clear? Fine. Now, let us look at the next part, which is your thyroid hormone resistance. So, what is this thyroid hormone resistance? Here there is mutations in your thyroid receptor beta. So, your thyroid hormone is not being able to act. So, the TSH levels are elevated or normal, but there is an increase in the unbound T3 and T4. So, what will it mimic? It mimics hyperthyroidism because the free T3, free T4 will be elevated. right? Because the free T3, free T4 are not able to act via the TSH receptor beta because of resistance. So, as a feedback mechanism, the FT3, FT4 will be elevated and the TSH may be normal also. So, you will misdiagnose this patient as hyperthyroidism. Okay? And why? Because you don't want to give unnecessary anti-thyroid drugs. The treatment for thyroid hormone resistance most often is conservative. There is no treatment that is required. So, you will misjudge and wrongly treat the patient as hyperthyroidism. That is why you should be aware of this thyroid hormone resistance. Okay? Fine. So, clear till here? So, till here, let's just recap what we have learned. We have learnt about the basic anatomy of the thyroid gland. We have understood how is the thyroid hormone produced. We have understood the difference between T3 and T4. We have understood what is euthyroid hyperthyroxanemia and thyroid hormone resistance syndromes. Now, let us look at the approach to thyroid function testing. Let us look at the approach to thyroid function testing. Okay. So, the measurement of thyroid hormones, which are the hormones that we require to find out the diagnosis. We look at the TSH. The latest assays in TSH can detect TSH levels to less than 0.01 units per liter. Okay. Then we look at the free T3 and free T4 levels. We don't look at total T3, total T4 because just now we saw there can be conditions of euthyroid hyperthyroxanemia. So, we look at the free T3, free T4 levels. Okay. Now, with this chart you can find out whether this is hypothyroidism, hyperthyroidism and different types of hypothyroidism. So, in euthyroid state, you can see that this is FT3, FT4 on the left and down we have the TSH. So, here in your euthyroid state, let me use another color, TSH is normal. What about the FT3, FT4? They are also normal. Okay. So, that is your euthyroid. Now, let us look at primary hyperthyroidism. Let us look at primary hyperthyroidism. Now, primary hyperthyroidism basically means what? Basically means that the thyroid gland is producing excess FT3, FT4. So, FT3, FT4 will be elevated. That is fine. Now, if the thyroid gland is producing excess thyroid hormone, then you will have a feedback inhibition on the TSH, correct? So, what happens to the TSH levels? The TSH levels will be low. So, in your primary hyperthyroidism, there is a problem at the level of the thyroid gland and not the pituitary. So, in primary hyperthyroidism, the FT3, FT4 is high. As a feedback inhibition, the TSH will be low. Okay, so that is what here it is. It is TSH low. The column is TSH low, but the FT3, FT4 is high. Okay. Now, let us similarly look at primary hypothyroid. So, we will finish here and we have finished here and now we are looking here. Okay. So, in your primary hypothyroid, you can just look at it the same way. So, what happens to the FT3, FT4? They will be low because the thyroid is not functioning. Now, because you have a feedback mechanism, what will happen to the TSH? The TSH will be high. Okay, that's what we are looking at. FT3, FT4 low, TSH high is this column. This is your primary hypothyroid. Okay, so now we have understood about your primary hypothyroid, primary hyperthyroid and euthyroid. Till here we are clear? There should be no confusion with this. There should be no confusion with this. So, in your primary hypo, FT3, FT4 low, TSH high. Primary hyper, FT3, FT4 high, TSH low. Euthyroid, everything is normal. Okay. Now, let us look at these conditions. Let us look at the other two corners, which is your secondary hypothyroid. Your secondary hypothyroid. So, what is the meaning of secondary hypothyroidism? It means that the problem is from the pituitary. So, TSH itself is not produced. Okay. So, here TSH will be low, FT3, FT4 will also be low. Can you see here we are looking at low and low. This is your secondary hypothyroid. Similarly, with your secondary hyperthyroid, this is a problem at the level of pituitary. So, there is increased TSH from the pituitary and there is increased FT3 and FT4. Okay, that's why we are seeing TSH high, FT3, FT4 high. So, it's very, very important to differentiate primary and secondary hypothyroidism, primary and secondary hyperthyroidism. Primary means problem at the thyroid. Okay, so just remember these two words. Primary means problem at the level of the thyroid, and secondary means what? Secondary means problem at the level of pituitary. So there is no feedback and all in your pituitary problem. TSH itself is high, FT3, FT4 will be high. If the problem is at the level of the thyroid, then because of the feedback, you will have your discordant pattern. Okay, clear till here? Fine. Now let us look at this entity, which is your subclinical hypothyroidism. This is very, very, very important because it can be confused to a large extent. So in your subclinical hypothyroidism, what happens? Subclinical means the thyroid hormone levels are normal. Thyroid hormone levels are normal. So FT3, FT4 is usually normal. FT3, FT4 is normal. Okay, but the TSH is high. That's why this is your subclinical. This is your subclinical. Okay, so this is your subclinical hypothyroidism. In your subclinical hyperthyroidism, again the FT3, FT4 will be normal and the TSH will be low. The TSH will be low. Okay, fine. Now, what are the conditions where the TSH is normal, FT3, FT4 will be high or low? TSH is normal. There are some variations in FT3, FT4. This happens in your non-thyroidal illness. This happens in your non-thyroidal illness, or what we call as sick euthyroid. We call as sick euthyroid. That means that in some patients, let's say they are very sick, they are admitted to the hospital, they are admitted for something else, lower respiratory tract infection, sepsis, etc. So that time the thyroid hormones can be varying, okay, but the TSH can be still normal at times, and this is what we call as the non-thyroidal illness. So in your subclinical hypothyroidism or hyperthyroidism, the FT3, FT4 is normal, TSH high in subclinical hypo, TSH low in subclinical hyper. Okay, fine. Now, many a times what happens is where we get confused. Let us look at where do we get confused. Where we get confused is your central or secondary hypothyroid versus your subclinical hypothyroid. Okay, so sometimes in your central or secondary hypothyroidism, the FT3, FT4 will be low, but the TSH will still be low normal. Okay, the TSH will be low normal. The TSH has not yet begun to drop. Okay, so in your central hypothyroidism, ideally what will happen? TSH will be low, FT3, FT4 will be low, but here the TSH will be low, or low normal, right? It's just about the cutoff, and the FT3, FT4 is low. In subclinical hypothyroidism, what happens? The FT3, FT4 is normal and the TSH is high. So never get confused that your central hypothyroidism can be misdiagnosed as your subclinical, right? Because you see that FT3, FT4 is low, TSH is normal, you think this is subclinical because TSH has not yet got elevated. No, you will be misdiagnosing this as a subclinical hypothyroidism. In a subclinical hypothyroidism, FT3, FT4 is normal, TSH is elevated. FT3, FT4 is normal, TSH is elevated. Okay, that is the main difference. So please do not get confused. Many a times when you interpret your thyroid functions, this is where we get confused. Okay, so this is how you interpret your thyroid function test. Okay, so you go back and try to understand this once again, it will become much more simpler. So this is your very, very confusing, very, very important point. Never misdiagnose your central hypothyroidism. T3, T4 is low, TSH normal, it is not subclinical. It is not subclinical, it may be an underlying central hypothyroidism which we have not picked up yet. Okay, fine. Now, we have understood how do you approach the thyroid function test. Now, how do you determine the etiology? How do you determine the etiology? So, first test that we do is an anti-thyroid peroxidase enzyme. So, what is the use of this anti-thyroid peroxidase enzyme? in 5 to 15% of the normal individuals also you can have anti-TPO positivity. But anti-TPO positivity is very useful in the diagnosis of Hashimoto's thyroiditis. It may be seen in 80% of Graves' disease as well. So, autoimmune thyroiditis, autoimmune hypothyroidism, always check for anti-TPO antibodies. Then you have your thyroid receptor antibodies, which can be stimulating antibodies, which are seen in 85% of Graves' disease. Then you have your serum thyroglobulin levels. What is the use of measuring the serum thyroglobulin level? So, in any form of thyroiditis, there will be an alteration in thyroglobulin levels. The thyroglobulin levels will never be normal in any form of thyroiditis. Okay. So, if you are having thyroglobulin levels normal, then this is a factitious thyroiditis. That means they are doing some malignant, they are doing some malingering, or there is some reason, there is some other reason. It's basically factitious. Okay. So, thyroglobulin levels, if they are normal, it helps differentiate factitious thyroiditis from an actual thyroiditis. The other use of thyroglobulin is that in the monitoring of thyroid C, especially papillary carcinoma thyroid after surgery, you basically monitor the thyroglobulin levels, and the target of that is thyroglobulin less than 0.2 nanogram per ml to ensure that there is no recurrence of your papillary CA. So, it is used in monitoring for papillary CA. Okay, fine. The next test that we do is your radioactive uptake test, or RIA, radioactive iodine test, radioactive iodine assay. So, what compound we use? We use the iodine 125. So, this is basically used for, is a type of radioactive imaging of your thyroid gland to find out the etiology of your thyrotoxicosis. Most often thyrotoxicosis, it can be used for other things as well. So, can you see that there is a diffuse uptake? So, there is a diffuse increased uptake. Okay. This is seen in Graves' disease. Okay. Now, there is no uptake at all in a nodular fashion, then that is a cold nodule. Okay. If there is increased uptake in one particular area, then this is a hot nodule. Okay. So, this is a hot nodule. And in thyroiditis, what happens? There is no uptake at all. So, to differentiate between Graves' disease, thyroiditis, cold nodule, hot nodule, we can use your radioactive iodine uptake. Okay. What is the advantage of this? Now, when you get a cold nodule, what is the relevance of that? There is an increased risk of malignancy, and hence the cold nodule must always undergo a FNA, fine needle aspiration. Okay. So, this is about your radioactive iodine uptake. So, with this we have come to the end of our session. We have understood your approach to thyroid function testing, we have understood the physiology of thyroid function testing, we have understood various other tests which are used to identify the etiology of your thyroid disorders. In the next session, we will be discussing about the disorders of thyroid per se. Thank you.